Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you have taken time out of your day to join with us as we explore more topics that are pertinent to the health and well-being of the Black community. Today, we are going to talk about, and may sound daunting, but when we get into it, you'll understand why we're talking about this. We're going to talk about neuropsychiatric consequences of traumatic brain injury. And these remarks are going to be brought to us by Dr. Cheryl Cottrell, who is a psychiatrist at Columbia University. In addition, we will address current events and try to keep us all abreast of what we need to know about to take care of ourselves. And without further ado, I will turn it over to Dr. Randall Maxey.
Good afternoon, everyone. Thank you, Dr. Neighbor Stevens, Dr. Ivan Walks, and Dr. Hines, and the venerable Dr. Wilbur Jordan, of course. We have an interesting topic on psychiatry and what happens when you have brain trauma or brain injury. And we're going to have a talk from our visiting psychiatrist, Dr. Cottrell. Is she on yet, Dr. Walks?
Not as yet, Dr. Maxey.
Okay. I was at a church today of Dr. Noel Jones, and he did a very interesting thing. He had a congressman-to-be and a congressman named Maxine Waters, and I know we're not political, but he prayed that if there's ever a time that our community needs a government that is fair, it's now. And he prayed that God continue to bless us and put the people in Congress and in the Senate and the governorships and offices all over the country that will treat our democracy good and take care of our communities. So what I'm going to do is ask Simon to let me share my screen. And until Dr. Cottrell comes on, I'm going to just remind people of a very bad problem that we have in something called prostate cancer, if that's okay. And if somebody would let me know as soon as they see Dr. Cottrell on. Give me 1 second here. Can you see my slides?
Yes, sir.
Well, this is a bit away from the issue of brain trauma, but it's something that is very important. Let me just get my slides up. Simon, if I send them to you, can you So prostate cancer, testing and treatment options. I'm going to take a minute and send these to you, Simon, so you can project them for me.
Dr. Lawson is on.
Dr. Lawson's on?
Yes, he is.
So Dr. Maxey, once you send the slides to Simon, maybe you could give us a little background on why you were doing the presentation today at church.
Okay, I will do that. Give me a second just so I can get my brain together. Was just trying to figure out what I'm doing here.
We'll give you the West Coast dispensation, Dr. Maxey, since it's just a little bit afternoon there. If you were on the East Coast, it would be after 3 in the afternoon. There'd be no excuse for not being totally prepared.
Okay. So Simon Cooper. And
So while you're sending those, Dr. Maxey, the reason I was asking you to give us a little background on why you would be doing that at church, we talk frequently on the Black Health Trust about the importance of physicians getting out of the medical arena and cross-pollinating or interacting with folks who are not in a medical office or a medical institution. And we talk a lot about churches and schools and places like that. So I thought it might be of some interest to know how you got connected with the church to do something like that.
it's a church that I've been asked to be the medical director of. And it's a large mega church. And so the First Lady and I did a program along with Dr. Cutter 2 weeks ago on breast cancer. And then we did one today on prostate cancer. And the bishop in his comments today said that if he had a town hall, nobody would come if they heard it was about cancer. But if he did it on Sunday morning, first Sunday morning, while everybody was there, everybody had to get the message. And I thought that was, we had a church full of at least 4,000 or 5,000 people. So I think it was pretty well received in that regard. So Simon?
And on first Sunday, you can do it ahead of communion. So you really know they're not leaving.
Yeah, but he did it after offering. Okay. So Simon, did you get him? Call Randy Maxey too.
Calling Randy Maxey II. Mobile.
Okay. All right. So we can go to the next slide. So we're going to talk about prostate cancer and testing and treatment options that are very important. Go to the next slide, please. You can see the slides okay?
Yes.
Yes.
Okay. What we're going to talk about today is about the prostate and understanding what prostate cancer really is, its risks and symptoms, how common it is, and what are the prostate cancer tests and what are biopsies and how are they, and questions that you need to ask your doctor and understand what your treatment options are. Next slide. So the prostate is the male sex gland and it's located right under the bladder and on top of the tube that your urine comes out, called the urethra. And it adds fluids to carry sperm. And there's a diagram to the right with little pointers to the areas that we're talking about. So the urethra is the channel that runs through the middle of the prostate gland. And when you have an enlarged prostate, that's where you may have trouble urinating, starting your stream, stopping your stream, because there's physical pressure on that. Let's go to the next slide. So prostate cancer and any kind of cancer is when abnormal cells grow out of control. And it begins in the prostate gland itself. And it can spread and invade tissues, organs, and bones. So it can get all over your body. Next slide. So 1 in 6 men will have prostate cancer during their lifetime. But fortunately, now 85% of prostate cancer are found early enough before it spreads outside the prostate, can therefore probably be treated with good results. 85%, that is. Next slide. So what are risk factors? Age is more common in men above age 40. And also it's more common in people that have a family history, such as father, brother, or son. But it is also in people's families who have somebody who has breast cancer. You also have a higher risk of cancer of the prostate. It's also more important that it occurs more frequently in African Americans as well as Latinos. Now, some people say that prostate cancer is an old man's disease. That's not true. It can happen to any age. And if you have the risk factor of family history, you want to start getting your PSAs and digital rectal exams early. Next slide. So some possible symptoms: if you have trouble urinating, if you have a weak urine flow. I remember when we were kids, we used to be able to see how far high on the wall you could urinate. But if you can't urinate high or over the wall, it's called weak urine flow. Frequent urination, especially at night, if you're getting up and down 3, 4, 5 times a night, it might be prostate cancer, not necessarily. If you have painful or burning urination, if you have blood in the urine or semen in your semen, if you have pain in your back, in your hips or pelvis that won't go away, if you have pain when you have ejaculation during sex, so that's something important. Now, you also don't have to have symptoms at all. That's the myth. In fact, most men don't find out they have prostate cancer until a doctor does a test and examination. Next slide. Well, if you do have prostate cancer, you want to know everything about it. You want to be knowledgeable. Next slide. So how do you know if you have prostate cancer? Well, there are certain tests we can do. There's a test called a PSA, which is called prostate-specific antigen, and it's a simple blood test, and we can find out if you're likely to have it. It is not diagnostic, but it can put you in the ballpark. The DRE stands for digital rectal exam, and it's a physical exam that the doctor does with his finger looking for bumps on your prostate exam. Next slide, on your prostate exam. Next slide. So the PSA test tells you if that PSA, that protein, is elevated. It does not diagnose and tell you for sure that you have prostate cancer. Your doctor will watch out either for a high PSA, but more important, if there's a sudden and sharp rise in that PSA. So a high PSA level may be prostate cancer, it may not be, okay? It may be benign. You may have just prostate enlargement secondary to an inflammation. But if you have a sudden or sharp rise in that prostate specific antigen, that's more likely that you do have prostate cancer. Next slide. So the prevalence of prostate cancer, if you look on the left, you see the PSA level in nanograms per cc, per milliliter, and it shows Normally, up to 0.4 nanograms per cc is considered normal. But if you compare those PSA levels with prevalence, and prevalence is the number of abnormals per specific population, you can see that it continues to go up, and with the higher numbers pointing to people who do have prostate cancer. Next slide. So, is anybody confused about having prostate tests? I'll tell you, it's simply a blood test. There should be no confusion. And the reason this is written like this, there was some literature earlier in the majority literature saying that you shouldn't go and take a test that might be inaccurate. It might make you think you have something or not. So discourage people from getting those tests. And part of that, I'm sure, was because of money. But part of it was like the whole thing about getting vaccinated, wearing masks, that they don't care because it's not in their community as much as it is in ours. So I believe everyone should get a prostate exam, whether it be a PSA followed by a digital rectal exam or what. Next slide. So before we had PSA testing, the majority of men who got prostate cancer, we found it when it was too late, when it had already metastasized and moved to different points of the body, and it was lethal. Next slide. So since we've had the PSA test, we know that there's been a 66% reduction in metastatic means spread, prostate cancer from the initial diagnosis. Over the past 20 years, age-adjusted prostate rates have fallen almost 42%. And NIH says that suggested more than 45 to 70% reduction may be attributed to earlier detection and diagnosis of prostate cancer. So, and there are now advances in treatment that make it not so devastating. Next slide. So, as in a previous slide, the NMA had to go against what the national testing bodies were saying, and saying that the benefits for Black men, we need to be tested. We need to have both the PSA, we need to have the DRE done, and don't even worry about psychological stress. It's better to get this done, and then we can put a group together. We can send it to Dr. Walsh, to Dr. Lawson, and they can straighten out the stress that you feel. Next slide. So not all prostate cancers require treatment. The patient is entitled to know whether or not he has prostate cancer and be allowed to decide what he wants to do about it. Next slide. So the R. Frank Jones Urological Society, which is a part of the NMA and the NMA section on neurology, support the use of PSA in early prostate cancer as a means to support the health promotion in African-American men. Moreover, the NMA endorses prostate cancer early detection. That's very important. So both the DRE, the digital rectal exam, which most men don't like, but it's not that bad, it's only a second, and PSA are part of the screening. An informed decision needs to be made. Next slide. So your doctor will use the biopsy results to find out if you really do have prostate cancer. If you have a test of an elevated PSA, that biopsy is an absolute diagnosis. Depending on the results, you and your doctor will decide if you have prostate cancer, if he needs to repeat the biopsy, and he'll compare this to previous biopsy results if you've had them, and he may order a bone scan or a CT or an MRI to confirm whether or not it's spread and to where. Next slide. So if you do have prostate cancer, let's go to the next slide. There are various stages, but let's skip this slide and go to the next one. And prostate cancer stage 1 through stage 4, and that depends on whether it's inside the capsule of the prostate gland or outside or into the bone. So it's your personal decision of what you do if you're diagnosed as having that. Let's go to the next slide. Now, just whatever one patient does for his prostate cancer should have nothing to do with what you do for yours. So here's some questions you want to ask your doctor. Is my cancer only in the prostate itself, or is it outside the prostate? Is it slow, or is it fast growing? What are all the ways that prostate cancer can be treated? What is the chance of a cure? What are the pros and cons of each treatment? How long will the treatment be? And how long will it take me to recover and get back to normal? What are the side effects? And what will happen to me much later? And we need to ask those questions. How do I control my bladder? Will I be able to have sex again? What can doctors do if prostate cancer returns or spreads more? And the last question you want to make sure you ask your doctor, well, doctor, especially if it's urologist, how much experience do you have? And can I get, or do I need a second opinion? Let's go to the next slide. So early detection and improved treatments have helped to save a lot of people. The chance of dying from prostate cancer has been reduced by 50% since the early 1990s. More than 2 million men are living today after being diagnosed early. Let's go to the next slide. So this looks at treatment of localized cancer. So what it means to you, if you do active surveillance, that means you don't have surgery, but you live with your prostate cancer and you get tested on a regular basis. So the PSA and digital rectal exam are done every 3 to 6 months, and you may get a biopsy once a year. Moving to the right, under surgery, the prostate and prostate cancer cells are actually removed from your body. Nowadays, the biggest operation is robotic-assisted surgery. It's minimally invasive and is often nerve-sparing because the erection in the penis depends on certain nerves being able to be there. And they also typically may do laparoscopic surgery, which is not based upon robots. There's also radiation therapy, and the cancer may be killed but not removed. There's brachytherapy, and that means they sort of freeze it, or cryotherapy. And then there's external radiation where they put a radiation beam to the prostate, or they may put pellets in there. So let's go to the next slide. So 5-year survival rates, this is how we look at cancer. Will you survive 5 years? So the 5-year survival rate of local cancer in the prostate that has not gone outside of the capsule is 100%. If it's distant, it may go down to 33.3%. Next slide. Now, to me, and I don't know if, can we see the right side of this slide? Simon, can you move this whole slide a little bit? Okay. To me, this is the most important slide. If you have active surveillance, meaning that you did not have surgery, you just have regular exams, but you don't do anything. 1 year later, patient continues to have monitoring, continues to have his DRE exams, but 10 years later, most of those patients are dead because they didn't get treatment. Go down to the next column where it says surgery. And for 1 to 3 days is the hospital stay in that. You usually get back to work within 2 to 3 weeks. At 1 year, most people regain their function of sex. They regain their ability to control their urine, and they're back to normal. But 10 years later, the majority of these people are alive and well, and there's a higher rate of survival with surgery. Radiation, and I'll just refer you to the last column. 10 years later, a higher percentage of those people are dead. So the optimum treatment of prostate cancer is surgery. No matter what else you do, is surgery if you qualify for it, if it hasn't spread, if you've gotten it in time. Next slide. So there is no solid theory on how you can reduce your risk for prostate cancer. However, as we've said in many of our programs before, having a healthy diet with fruits, green vegetables, helps reduce risk, reducing fat in your diet, and especially if you eat barbecue, if you grill, that charred meat and even charred vegetables can be something bad and make the incidence of cancer go up. There are certain herbal treatments that are probably good for any kind of cancer and good health. All of your vitamins, your antioxidants, and eating your food colors are good to help reduce your risk for prostate cancer. But most men that are Black at some point are going to get prostate cancer. So it's important to find out if you have it, whether it's conservative cancer or whether it's aggressive cancer, and then what can you do about it? So with that, I'll open the floor to any questions and see if our guests has come for our main talk.
So while you're opening for questions, Dr. Maxey, I did speak with Dr. Cattrall. She was having some technical difficulties and is hoping to be able to join us within the next few minutes.
Oh, great.
So I saw Dr. Jordan had a hand out, Dr. Maxey.
Go ahead, Dr. Jordan.
Okay. I had prostate robotic surgery in 1998. And I think it was easy then. It's certainly been easier since then. I'm one of those that believe in having the surgery, getting rid of it altogether. But the thing is, we've got to get Black men, because in terms of the data you showed, it's probably 1 in 3 or 1 in 2 Black men will have prostate cancer. And if they're not going to a doctor, they don't have anyone. You can't go to an ER and ask them to draw a PSA. Again, we need to encourage Black men to see a physician so the physician can order a simple test to do it. We could have groups to have people talk, but I don't understand any reason. Robotic surgery is very easy. So it has gone from when we were in medical school, a horrible thing because you had to stay in the hospital for over a week because of the bleeding, to now where you can go in one day, have the surgery, and go home the next day. The biggest thing in terms of the whole process is doing the digital rectal exam. And I think that's important. And a lot of men, particularly men who are closeted, don't like having that done, but it's necessary. But biopsy is what hurts like hell when you have it. Because if you have an elevated PSA, then a urologist is going to do a biopsy to see if it's normal tissue that's growing or if it is cancerous. And if it is cancerous, you need to take it out. I mean, I'm a proponent of just take it out, period. You will have 6 months of struggling, but then everything becomes okay. So that's
Well,
my
I-
thoughts on it.
So,
think
so Dr. Maxey, Dr. Cottrell is on, and we can make sure that she can have her time to get to speak to us.
Okay, very, very good. Any other questions on the prostate while we're at it in the chat or anything?
In the chat, there's a question about whether surgery is the only option, and then another question about if the cancer has spread outside of the prostate, what are the options?
Okay, to the first, surgery is not the only option. It is simply, in my opinion, and the opinion of the surgeons that I've talked to, the best option. And hopefully you've caught it while it was totally in the capsule itself. And I showed you the 10-year survival rates. And the 10-year survival is much greater if you've had surgery. And now, since the invention of robotic surgery, those numbers are even better. One comment on what Dr. Jordan said, the biopsy itself in some hands is painless. And if done right, they usually do 12 samples, but it does not have to be something bad. And but talk to your doctor about it, and it is not necessarily that bad. If it has spread, then you may not have many options. You certainly want to get rid of the primary. You might want to use a combination of hormone therapy, brachytherapy. But if it gets loose on you, it can be a bad thing. It can go to your liver, your brain, your lungs, any place else. So it's important to get a hold of that cancer while it is early. And maybe on another show, we'll talk about more about nutrition, which seems to be the best thing for everything. But let's move on. If there are no more questions, we thank Dr. Cheryl Cottrell for joining us for our stated lecture for today. You want to introduce her, Dr. Walks?
First of all, let me apologize to Dr. Cottrell because we had some issues getting all the information to her and getting some of the detailed information from her. I saw Dr. Lawson earlier, who was going to introduce her, and Dr. Lawson may have gotten cut off because I don't see him on right now. Dr. Cottrell, as Dr. Lawson shared with me, is someone who is a psychiatrist, is someone who is a neurologist, and who her email, part of her email says it all. It says all brain on the email. And so I thought that was just excellent because it indicates that she is able to talk with us about what impacts the brain. Our talk today is on brain trauma, and that's what we would like to hear from Dr. Cottrell about. Dr. Cottrell, are you able to be unmuted and to join us at this point?
Yes, I am. Can you hear me?
Yes, ma'am.
Okay, and my techs are here. My kids are my tech help, so that we'll try to get this underway.
Should I go now?
What?
Should I share the thing?
Yeah, share the.
Okay.
Okay. Simon, does Dr. Cottrell have screen share privileges, please?
Are you on?
Does that work?
Yeah, it's just like,
Okay, so can you folks hear me and see the slides?
We can hear you. We cannot see the slides
They
as
can't see.
yet.
okay.
They
hold
can't
up.
see the
Give me
slides.
a second.
It sounds like you have your multi-generational tech team walk in
That's
there.
right, the Cracker Jack tech team. That I would
That's
not be able to do this
exactly
otherwise.
how it works at my house.
Show content.
Do I have
Not yet. Okay, can I see your screen? Hold up. Okay, so it's sharing the screen. Can I see it now?
Can you see it now?
Yes.
Yes.
Are they able to see that I'm setting it up?
So we can see your screen now.
What in the world?
I can
Okay,
see it now.
give me a second. It skipped to like the front of the thing. So here we go.
There we go. Oops.
Why is it not working?
We can see slides. They're going forward.
It's
Yeah,
like not
they can see-
working.
They can see
I know, but it's not working.
what's not working.
This thing itself.
Okay, looks
Wait a
like we have
second.
the first slide.
There we go.
Okay.
Take-
So I'm so happy to be able to use this venue to talk to you today about the neuropsychiatric consequences of traumatic brain injury. I think that this is such an important topic. This is something that I have spent most of my professional life looking at and treating patients who have had this illness in various venues. I guess I started the training and my teaching and work with traumatic brain injury patients when I was at the University of Medicine and Dentistry in New Jersey. And I was a liaison to the trauma unit there. And that trauma unit had a combination of patients, the patients who were from the inner city of Newark who had gunshot wounds, stab wounds, different trauma from that. And the second part of patients who were on that ward were the patients who were flown in from helicopters from motor vehicle accidents or industrial accidents that happened on their jobs. And so this was a level 1 trauma center that we got a chance to see a lot of different things. And it certainly piqued my interest in this topic, and certainly made me go on to other employment. I was working at Yale with the veterans of the Vietnam War and talking to them about post-traumatic stress disorder and generational PTSD, and really got a chance to see patients who were not so much physically injured as they had been on the trauma service at UMDNJ, but more psychologically wounded and had to be managed and taken care of from that vantage point. I also got a chance to work with another population of active service members who were stationed in Groton, Connecticut. And they were coming in from the Afghanistan conflict and had suffered blast injuries and other types of physical trauma again. And was happy to be able to hear their stories, work with them, try to treat them in whatever way we could. And then ultimately, I've worked with patients who've had their own histories of domestic traumas through violence, both in terms of women having boyfriends or husbands who have been physically traumatizing to them, or children who have been physically traumatized through shaken baby syndrome and other things. So that talking about this area of traumatic brain injury almost spans my professional lifetime in terms of what I've been able to see and how I've seen that the whole area has changed and developed and really become a very important focus of American medicine today, as it should. And so today I'd like to just spend a little time, if I can get the things to start to work. Hold on just a minute. And I need my tech assistance again. Angel?
What?
I can't advance the slides.
Just click the screen. Just click the corner.
Okay, so here we go. This presentation today, I'd like to talk about a little of the epidemiology of traumatic brain injury, the severity of it, the types, the symptoms, the measurement of traumatic brain injury, as well as the measurement of the cognitive and behavioral symptoms. And then I'd like to flip to a case study of a patient who I am currently treating, who was involved with a motor vehicle accident approximately 6 or 7 months ago, and who represents some of the issues that are present with traumatic brain injury, but are seldom recognized on first blush. So let's start here. The prevalence of traumatic brain injury. Each year, approximately 2.5 million people will have a traumatic brain injury in this country. 50,000 people will have deaths from traumatic brain injuries, and 80,000 people will suffer permanent disability. Of the 1.5 million Americans who survive traumatic brain injury, 230,000 are hospitalized, and that number is growing. That in 2000, in the year 2000, 10,958 were diagnosed with having traumatic brain injury. But as of 2015, 3,400, 34,000 people have been diagnosed. So it is being recognized and diagnosed exponentially almost in the last 15 years. The leading causes of traumatic brain injury seem to be falls as the number one cause, led by, then found by struck for and against, as well as traumatic traffic accidents. Just a minute. The prevalence of lifetime traumatic injury is much higher, though, than in vulnerable populations than it is in the general population. So that you see that the general population, traumatic brain injury with loss of consciousness, there will be 22%. There will be a prevalence of lifetime prevalence of 22% in the general population. That is considerably higher in substance abuse settings and in prisoners and homeless people. The factors that increase the likelihood of having lasting effects from traumatic brain injury include the severity of the TBI, the cumulative effects, both in terms of the severity of the injury, the longevity of being ill, the developmental interaction, having had recent other injuries, and whether there are other neurologic disorders that are present at the time of the traumatic injury. So that the person who has had a traumatic injury who also goes on to have seizure disorder, which is a common sequelae of traumatic brain injury, is probably at more risk than the person who is just having a traumatic injury with by itself. There are two types of traumatic injury that I wanted to, two types of acquired injury that I wanted to talk about. And I want to leave more the traumatic brain injury. I want to focus more on just a traumatic brain injury rather than the non-traumatic brain injury, which we see in strokes and tumors and metabolic disorders. So the traumatic brain injury can exist with both an open brain injury and a closed brain injury. And similarly, you can get assaults, falls, accidents, abuse as causing both open and closed brain injury sequelae. The types of brain injury, traumatic brain injury that we're going to be concerned with are concussions, which are a big portion of the traumatic brain injury population. Epidural hematomas, subdural hematomas, subarachnoid hemorrhages that make up this thing. If you look at the left side of your screen, you get a chance to see the epidural, contusion, subdural, diffuse axonal injury, and subarachnoid hemorrhage as they look on the brain itself. And the right side of the screen talks about the layers of the brain that the blood collects in based on what type of trauma they've had. So if you have a subdural hematoma, the blood is collecting under the dura mater. If you have an epidural hematoma, the blood is collecting above the dura mater. And if you're having a subarachnoid space, subarachnoid hemorrhage, the blood is collecting in the arachnoid spaces. And so this is a kind of nice way of being able to see what you're looking at on x-rays or CAT scans of what is actually going on. The concussion, I can't get the notes. Let's see, I need to move back. Where? Okay. Okay, so the concussions as the first part of a traumatic brain injury that used to be not necessarily even included in the traumatic brain injury roster. But we found that there's so much that can happen from just concussions alone, that certainly has now started to be included in the whole roster. And so the person who has a motor vehicle injury where his head is kind of in a whiplash situation, he hits the front of the dashboard, and his head is jerked forward and then it's jerked back. Those acceleration, deceleration injuries are very common in concussive states and cause all of the symptoms of loss of consciousness, amnesia, everything else. Only thing that is not seen with a concussive syndrome is that you can't necessarily see anything on a CAT scan or an MRI. So imaging does not reveal the problems that have happened because of a concussion, but those problems are very real. Similarly with blast injuries that a lot of the servicemen were experiencing, where their Kelvinar helmets were hit by debris and stuff like that. They had what they call their bells rung. They were very shaken and shattered by that, but we would take them for MRIs, we would take them for CAT scans, and pretty much it was not, nothing could be found in terms of what had happened to them. But the concussion is an important thing to make note of, as well as an important thing to follow over time. There is two things that we want to look at, both the second impact syndrome that a lot of athletes go through, where there is a second injury, a second concussion that happens. And during that situation, there's more rapid edema that develops in the brain and can cause certain consequences that we'll talk about later. And the other part of the concussion, of the concussion syndrome that we want to be aware of, is the chronic traumatic encephalopathy that we see with a lot of the athletes, the football players especially, where they've been hit in the head several times. They've had repeated mild traumatic brain injuries, but nothing so much that would actually appear on an MRI or other imaging studies, but they have deteriorations in their both cognitive abilities as well as their personalities, such that they have attention deficits, they have problems with memory, they have problems with executive functioning, and they are vulnerable for other dementing-like symptoms. The epidural hematoma is the second thing that we want to talk about just briefly. And as we talked earlier, it's a pooling of the blood between the skull and the dura mater. And it's secondary to a rupture of one of the arteries in the brain called the middle meningeal artery. And the symptoms with all traumatic brain injuries seem to talk about confusion, dizziness, drowsiness, maybe even an enlargement of one eye or one pupil versus the other, a loss of consciousness. And with the epidural hematoma, there is a period of loss of consciousness and then a period of alertness, and the person then deteriorates into loss of consciousness and more serious outcomes. The subdural hematoma is the next traumatic brain injury we wanted to talk about. And I'm going to go through these very quickly because the subdural hematoma is something that a lot of elderly people may experience. It is secondary to rupturing of bridging veins in the brain. There's the same types of things happen. There's a headache, confusion, drowsiness, some nausea and vomiting, slurred speech, changes in vision. And depending upon how much blood collects in the subdural spaces, it may be an acute medical emergency, or it may be an emergency that is protracted over time. It really depends upon how fast the blood accumulates and whether it can be absorbed in the tissues or whether surgical intervention is necessary. And finally, what I wanted to talk about was the subarachnoid hemorrhage, which is the entity that the patient will be talking about had initially when she first was involved in her trauma. And the subarachnoid hemorrhage, the person complains of sudden onset of a severe headache, sometimes loss of consciousness. Now, the subarachnoid hemorrhage is a kind of third rule. 1/3 will survive with good recovery, 1/3 will have disability, and 1/3 will die. And some of the risk factors for developing subarachnoid hemorrhage outside of trauma are smoking, hypertension, polycystic kidney disease, cocaine, methamphetamine, and blood thinners. Brain contusion is, there are scattered areas of bleeding on the surface of the brain, most commonly around the undersurface and poles, like in the frontal and temporal lobes. So that, as we were talking about earlier, the acceleration, deceleration injuries that happen with concussion, you don't see any of the contusions in the brain, but with more severe injuries, you may be able to see that. So, and as we were talking about, traumatic brain injury symptoms are myriad, and they fall into both the physical symptoms as well as the mental or psychological symptoms. And the physical symptoms can be the loss of consciousness, severe headache, nausea, vomiting, loss of coordination, sleeping disorders, convulsions or epilepsy, dizziness, loss of balance. The psychological parts of traumatic brain injury can be depression, inability to concentrate, suicidal ideation. We will talk about many of those things later on. There have been some reports about what were the psychiatric disorders that happened before brain injury versus after brain injury. And the population that seems to be most vulnerable before and after brain injury seems to be the substance abuse population. So the alcohol abuse, the cannabinoid abuse, even the cocaine abuse seems to be very, very high in terms of being vulnerable to psychiatric disorders after traumatic brain injury. The other population that is very vulnerable are the major depressive disorders. So, and so there have been a couple of different studies to try to say, what percentage of subjects with new mental disorders will have had traumatic brain injury. And so depression seems to be high on the list in terms of that. And going down the scale, personality disorders, alcoholism, and finally panic disorder and psychosis. Interestingly enough, PTSD did not rank in this series of studies. And so we'll have to see what that is all about in future work. But the pathogenesis of traumatic brain injury pretty much has to do with the inflammatory response. The inflammatory response of the brain causing edema on one hand, or vasodilation, and the rupture of the blood-brain barrier, and that causing hemorrhage and neuronal and axonal injury. And the secondary process of trauma is the oxidative stress, the demyelination, and even the neurodegeneration and programmed death that can happen from the inflammatory process. So it's not just that the brain may swell and cause life-threatening consequences because of that, but there's a secondary process where there is a kind of programmed cell death that can happen in inflammatory responses too. And this is a very chaotic slide. The long and the short of it is that inflammation inducers like infection or tissue damage cause inflammatory sensors like mast cells and macrophages, and inflammatory mediators are cytokines and chemokines. And these all work towards starting the process of healing. And sometimes the process of healing is not, the process of healing does not wind up in healing, but winds up in making more of a problem, such as the edema that we're talking about. But moving along to how do you talk about or understand traumatic injury more, the gold standard is the Glasgow-Coma scale, where there are 3 different areas that the person is being looked at when they are being assessed: their eye opening, their verbal response, and their motor response. And the person can achieve a score of 15 if they have all things normal in terms of the eye opening, all things normal in terms of the verbal response, all things normal in terms of a motor response. And that's the mild traumatic brain injury. The person has a better recovery, better chance of recovery, and less possibility of hospitalization and less possibility of other sequelae. The person with the moderate or severe Glasgow Coma Scale is not as fortunate and may have other complications to their course. Other things that we've used in terms of assessing a person's abilities after trauma have been the mini mental status exam and the MOCA testing. These are widely used exams both in trauma settings as well as in other settings, dementia settings, general hospital settings, and they give a kind of quick and dirty understanding of the person's visuals, executive pathways, their ability to name, their short-term and long-term and delayed recall, their language, abstraction, and their orientation. And so we use that in trying to assess the person's initial cognitive setting, or cognitive performance after a traumatic brain injury. But the other things that we use for traumatic brain injury and that we have depended upon a lot in recent years has been brain imaging. And brain imaging, gives us, in the case of the CAT scan or the MRI, whether the anatomy of the brain is intact. So is there, for instance, hematoma? Is there, for instance, a fractured skull? Is there, for instance, the fluid that's accumulating in one area of the brain or not? And so the CAT scans and MRIs have made an incredible difference in terms of being able to figure out what is happening with the trauma person who is initially in the emergency room and can't give a history themselves, and has, waning Glasgow Coma Scale scores. But there are other imaging techniques that have been used, and one of them is the diffusion tensor imaging, which has been used to detect axonal injury for mild to moderate traumatic brain injury, and the functional MRI, which is used to study activation patterns, and the SPEC scan, which now people are suggesting may be the most important thing to include with the examination, the initial examination of the traumatic brain injury person, because the CAT scan and the MRI may may present as completely normal, but the SPEC scan is much more able to detect cerebral blood flow and activity patterns, and it can show changes in the absence of anatomical findings. And then the EVOX is another test that I won't talk about right now, but it is a kind of combination, a neuropsychiatric test that has 5 different measures: mental health, behavior, heart health, brain processing speed, and brain health in terms of EEG comparisons. That might be useful for future discussion. Now, I want to talk right now about the case study that I wanted to present, which is a 27-year-old female who in March of this year was a backseat passenger of a car that was hit by a truck at high speeds in North Carolina. She was not considered, she had no loss of consciousness at the scene, but she reports that she was dazed and confused, and the EMS people felt that she was a little confused at the scene, but was able to pull herself together. She had a brief loss of vision, which has not really been documented what that was, whether that was her being dazed, whether she had a slight seizure episode, or whether that, it's hard to understand what that was. Further testing, ophthalmologic testing revealed no abnormalities. The EMS determined that her Glasgow Coma Scale and her vital signs were stable. They offered her an emergency room examination and possible hospitalization, but she declined, and then she went home. 5 hours after her injury, she developed a very severe headache, and then went back to the emergency room to get more evaluation. Her Glasgow Coma Scale was still stable, but her CAT scan showed a tiny subarachnoid hemorrhage. And patient at this time decided to accept hospitalization for several days of observation. Her serial labs, her EEG, her CAT scans, her carotid and intracranial Dopplers were all within normal limits. Subsequent serial MRIs, as I said, were all normal, and she was discharged from the hospital in North Carolina and came back to New York. She continued to have difficulty with sleeping and became anxious about resuming her daily routine of work and school. She denied having any thoughts, any traumatic recollections or nightmares or sudden arousals about the event, as might be seen with somebody who was going on the path to have PTSD, but she was having difficulty in sleeping. And she continued to report that the difficulty with concentration and memory was such that she was unable to remember what she had read. And she described lapses in memory during daily conversations with friends and family. And after getting back to New York and thinking that she would go right back to school, she ultimately asked for incompletes in March, and said that she would finish out the spring break just recuperating at home, and that she would enroll in the summer to complete her other courses. Her past medical history was non-contributory, pretty much a healthy young woman. She did, however, have a chronic history of depression since childhood, secondary to a chaotic family life. And she had a history of psychiatric hospitalization in 2018 with suicidal ideation, secondary to a breakup with her boyfriend. Her social history: she works full-time and she attends school full-time, pursuing a second master's degree. And she admits to recreational use of cigarettes, marijuana, alcohol, and cocaine, but does not feel that those have interfered in the past with her ability to work and or study. Her developmental history: both parents have been addicted to alcohol and drugs. As mentioned earlier, she had a chaotic family life, ending recently in her parents' divorce. She describes her father as verbally abusive to both her and her mother. And she also describes as having had suicidal ideations without a plan or intent or a gesture in her life. And the past social history again, that she was an honors student working on her second master's degree at the time of the accident. Her first master's degree was in social work. She also worked full-time prior to the accident in a nonprofit agency. And she lived alone, but was close to her mother, who lives in New York, and her older sister who lives in Baltimore, and no history of active drug or alcohol abuse. Now, her lab results have been very interesting. Her Glasgow Coma scale, as I said earlier, was 15. Subjectively, she described herself as mentally slowed, difficulty retaining new information, hard to multitask, difficulty with concentration, memory, and organization. Her mini mental status exam showed a 28 out of 30. I think that she got caught up with serial sevens, as most of us would. And her MOCA exam also showed 28 out of 30. I think she had some difficulty with tapping for attention. But the EEG was normal, the MRI was normal. And it was only when we started to do more specific testing or more specialized testing that we actually saw some changes. And so that the MRI with neuroquant sequencing, which is a very specialized MRI thing, showed that she had low hippocampal volumes for her age and her sex. And the SPEC scan showed mild asymmetric decreased cerebral perfusion in the right parietal temporal region. And these are not her scans per se, but these are scans of what she experienced, what her hippocampal volumes on the neuroquant MRI showed. And this is how her SPEC scan, this is not her SPEC scan, but this is what her SPEC scan showed with right parietal temporal normal decreased perfusion. And so essentially we have a person now who is 8 months almost after traumatic brain injury, after what she originally was not even willing to be hospitalized for, but ultimately got hospitalized and saw a slight change in her MRI. But as further examination, she shows much more troublesome pattern in both her both her SPEC and her neuroquant MRI scanning, suggestive of possibly executive malfunction. The things that she has complained of in terms of organization, in terms of memory, in terms of planning, may in fact be something that we have to look at further based on these findings. And so, you know, I wanted to bring her to your attention because so much of what is happening in traumatic brain injury is we're just at the tip of understanding what has gone on or what goes on when a person gets injured. And so many times a person will complain, and I can remember this so bitterly with the active service people in Groton, Connecticut, saying, you know, I'm just not the same person that I used to be. I'm just not able to remember things. My personality is even different. My ability to control my rage, my ability to control my depression is just not the same as when I first went to war or when I first got injured. And we would back then, which was 10, 15 years ago, send them for MRIs without these specialized testing, and they would come back normal. And people would say, oh, well, you know, you're just a malingerer, or you just don't know what is happening, or you don't want to be in the war, or you whatever. And so often this has happened in not just military situations, but in other situations too. And so I think it's real important to hear the history that people are giving, saying, you know, that my cognitive changes are not necessarily due to depression, are not necessarily due to sleep difficulties, but there is something anatomically different about what my brain feels like, looks like since I've been injured. And so it's nice that we are starting to have these new techniques and new technologies to validate people's response, people's feelings. But the whole issue of executive brain dysfunction versus ADD versus depression versus psychosis may really need to be teased out a little bit more as we go on with, you know, our treatment of traumatic brain injury patients. And then treatment strategies are something also that we need to look at more, not only in terms of the immediate changes that maybe the stimulants may be helpful for, but more in terms of long-term changes of, okay, have we started a cascade with the inflammation and the trauma, the brain trauma that has happened to patients that makes them more vulnerable for neurodegenerative processes. And so we need to really look at how we are treating the patients. Are the antidepressants, are the anti-anxiety agents enough of a portfolio for us to use in terms of managing the traumatic brain injury patient? And now I think I'd like to turn this over so that I can hear other people's discussion. Thanks.
So Dr. Cottrell, thank you so very, very much for bringing this information. We are, I don't know, Dr. Maxey, we had Dr. Cottrell's presentation partner, Dr. Lawson, on a few weeks ago, and we got to a point where we were running out of time, and we had about 73 questions that we needed to ask, and actually weren't able, just as now, to begin looking more deeply at what do we do when someone comes in. What are those treatment strategies, Dr. Troll, that you started to mention? So I'm going to start the question and comment by saying we are just about out of time, and we are going to beg you to come back so that you can talk to us about what we so just because this is your first time with us on the Black Health Trust. I want to say that our audience includes a lot of physicians, and it includes a lot of lay people, not only on the Zoom call, but also on YouTube and other formats. And so we definitely want folks to be able to, what do I do? For example, this case you laid out is perfect. A young person working on their second master's degree who is absolutely intelligent and a great addition to our society, and now has an accident that, you know, kind of, well, it was a bad accident and I hit my head really hard, but then I felt okay. And now we have these months of challenges. So we really do need to have more time to, so can I start the first question with, can you come back and spend more time with us?
Well, I would love to. You know, I flipped over a couple of the slides because I didn't want to run out of time, and but I could talk on this forever and ever.
No, we
Well, let
thank
me
you for
kick
coming.
it back to Dr. Maxey to kind of give us a little guidance at this point.
Well, I appreciate you, Dr. Cheryl, for being with us, and I concur with Dr. Walks. We'd love to have you back. And but let's get in a few questions while she's here. Dr. Neighbor-Stevens and Dr. Hines, and if there's anything in the chat, let's give her a few of the 73 questions. Let's do at least several of them.
I'll jump in, and this is an excellent presentation, and I really resonated with the presentation that you described, because I've treated these types of patients before. So my real question, I'll keep it short, is what type of specialist should someone be looking for when, just like you laid out, that top level scans, those top level tests aren't showing you anything, but this person is saying there's still more going on? What is the type of specialist that they should be looking for, or we should be recommending them to see? Or,
You know, I think both a neuropsychiatrist as well as a psychiatrist is able to listen to what the person is saying, and not just go through you know, the perfunctory exams and say, oh, well, you know, everything seems as if it's okay. Maybe to dig a little bit deeper. If the person is reliable, seems as if they're credible, and the you know, and what they're testing doesn't seem to, what they're complaining of doesn't seem to check out in terms of nothing's wrong. I think that the neuropsychiatrist and the psychiatrist are the very first people who do this type of work.
Yeah, let me ask a follow-up question. Until recently, I hadn't heard that much about neuropsychologists, psychiatrists. Where would the average person find them? Do you have to go to Columbia to find them? Look them in the yellow pages? How would we find the Dr. Control?
I'm not sure that I have a specific place, but neuropsychiatrists, I think, are a rare entity in that a lot of the testing, a lot of the you know, cognitive testing have been done by psychologists.
Yeah.
The neuropsychiatrist is the person who can do cognitive testing, but also can you know, prescribe medications. And so that's a little bit different. And there's a little bit more of an advantage.
Dr. Neighbor-Stevens?
I'm sorry?
You're on mute, Doc.
Me?
Sorry about that. I have a lot of questions, and I look forward to the return, because for one thing, I'd like to hear some conversation between Dr. V and Dr. Control. But I want to go back to something that you were hitting on, Dr. Maxey, which is one of the tragedies in our healthcare system, which is we need to get away from the thought that we have the Lone Ranger who is going to be able to do everything, and transition to a mode of thinking where healthcare is a team sport. And when a physician is confronted with a situation where the answers are not immediately obvious, and there needs to be a different approach to get to the bottom of the story, we need to really try to push. And I'm not talking to the doctors now, really. I'm really talking to our lay audience. And I know you're thinking, now, how in the world do I have any impact on that? Well, directly and indirectly. For example, if your employer-sponsored insurance or your Medicare insurance carrier provider network is not meeting your needs, there is consumer pressure that you can exert to try to force the issue to expand the net and get access to more thought to evaluate your situation. And I don't think that, I want people to stop thinking that there's nothing I can do and throwing up my hands. There's stuff everybody can do. Now, there's certainly some work physicians need to do. I'm not saying there's not, but I really wanted to tap into the consumer's power in forcing things to happen.
So let me run to Dr. Sherrod and then to Dr. Lawson, please.
Thank you, Dr. Walks. I'm going to be brief and short, but I concur with Dr. Neighbor-Stevens in that we need a team approach to this particular diagnosis. And I personally want to testify that it was actually an integrative medicine. We need an integrative medicine approach. It was my acupuncture. I had car accident, CT scan negative, MRI scan negative. It was really the quantitative EEG, which I don't hear anybody talking about in the traditional medical arena, which picked up concussion injury, which was missed by all of those big tests that she even had the SPECT scan. So it's very important that we do an integrative approach, and what can seem like a mild accident with no problems, as she has illustrated in her case presentation, can be major impact on your life and your ability to function in general.
Absolutely.
Yeah, so I wanted to ask her, does she know about the quantitative EEG? And is that traditionally recommended now in traditional medicine? Because it was my acupuncturist who said, I'm going to get a quantitative EEG on you. And that's when we found that I actually had some results of that my symptoms could be explained by concussion injury.
Well, that's what I was going to, I had brought the slides on the EVOX, but her results for the EVOX, I was not able to get the results of the EVOX study yet. But the EVOX is the quantitative EEG that also measures neuropsychiatric challenges and brain functioning and EKG functioning. So the EVOX is a kind of all comprehensive system. And I agree that the EEG is a measure that we should be utilizing more than we have. And we have just been utilizing the regular EEGs that don't really map out or compare your results to a larger database.
Well, I thank you, Dr. Control, and we do want you back. We're going to coordinate that. And like Dr. Neighbor-Stevens, we want to make sure we've had some wonderful neuro talks in the past few months. We'd like to get that group together as well.
So Dr. Maxey,
just a moment. I had told two people. I wanted them to put something in the chat. One is Dr. Rhonda Sherrod. We're trying to help her grow her database. She's the one who spoke to us about mental health as well and abuse. And also, if Dr. Motley is on, I want him to put in the chat. He's been nominated for Artificial Intelligence Innovator of the Year. And he wants people to vote for him. If both those individuals could put their information in the chat. And also, I want to announce that we're going to have a medical advisory meeting this Wednesday at 5:30 Pacific, 7:30 Central, and 8:30 Eastern. And our speaker will be Dr. Ann DeWeese Allen, and the topic is brain nutrition affecting brain dysfunction. And I want to make sure I get that in before Dr. Neighbor Stephen pulls the plug. What were you saying, Dr. Walks?
I wanted to
Yeah,
give
Dr.
Dr. Control's presentation partner, Dr. Lawson, is with us. He was on a few weeks ago and also left us with 73 questions. So if we could unmute Dr. Lawson to make a final comment before we close up today.
I just want to again thank you and thank Dr. Cottrell. And one reason I encourage to have her on is because this is an area that we really need to have more utilization of. What we don't talk about is how this impact the number of people who are in the correctional system, children who face a lifetime of dysfunction because of failure to not recognize these problems. The technology is unfortunately is not new. I was working with focused EEG studies a decade ago at NIH, but it's not getting into the population. We're not getting the data for people of color like we should. And even if we get them, problem we're running into, like, can we get people trained as neuropsychologists, neuropsychiatrists? Dr. Patel is unique that she's trained in both, but it's very uncommon. As a colleague of mine, Tony Strickland, who's been pushing for years to be able to get more neuropsychologists trained and work with neurologists, psychiatrists, and other team members. And if we do that, we run into another problem. Can't get insurance carriers to pay for it. They won't pay for it. And that is a major, major problem, which limits not only the utilization of this work, but also the innovation, getting this into the additional research so we can better understand these problems that are usually related to social forces and not to genuine neuropsychiatric issues.
Okay, absolutely.
Well, thank you, Dr. Lawson. Are there any, is there one more question in the chat, Dr. Walks?
Dr. Maxey, there are some other questions in the chat. I know that Dr. Neighbor Stevens is going to be concerned about the time. I think what we can probably do best is to just promise folks that if there are questions, they can send them to us at Black Health Trust, and we will try to process those, and that we will get a commitment from Dr. Cottrell and from Dr. Lawson to come back and spend more time with us.
Dr. Walks, can I just say one thing? I just want to announce the neurofeedback form of therapy. There's a new one out now called high performance neurofeedback. And sometimes we in the traditional medical professions do not know that, but that was very helpful in my recovery from the concussion injury that I incurred. It's called high performance neurofeedback. And there is one Black lady who is a psychophysiologist, but I had to get that therapy in such a roundabout way. So that's why I think we need to really have more discussion on this and how you approach the treatment, because it can affect your life immensely.
Well, thanks, everybody. Thanks, Dr. Sherrod. And briefly, is the other Dr. Sherrod available just to put her information in the chat? And also,
she did put it in, Dr. Maxey. It's in the chat.
And Dr. Motley, is his information in the chat?
I do not see Dr. Motley.
Okay, and Dr. Control, I'd appreciate you sending me your contact information if you would.
All right.
So final words, Dr. Hines, Dr. Walks, and Dr. Neighbor Stevens, we have a few seconds.
So again, I just wanted to thank you, Dr. Control, for the excellent presentation, and there's so much to ask and so much to talk about. So I'm looking forward to the next round.
All right.
And my little quick comment is, again, thank you, Dr. Control. Thank you, Dr. Lawson, for bringing Dr. Control to us. And we look forward to a lot more with you all. This is so important.
Thank you.
And I too wish to give my thanks to having this area opened up for all of us. I also would like to just quickly say, as a follow-up of last Sunday, Pfizer announced this week approval of a drug to treat RSV in Europe, and the trials are currently underway in the US, and the whole process. It is not anticipated to be available during this season, however, and it is a monoclonal antibody-based therapy.
Well, thanks everybody for attending today and for the spirited discussion. And for those of you that come to our medical advisory meetings, we're going to have a live one on Wednesday evening. What date is Wednesday, Dr. Walks?
It's the day after Tuesday, Dr. Maxey. I don't have a calendar in front of me.
Dr. Neighbor Stevens, Dr. Hines, when do you guys
It's the
know?
9th, November 9th.
November 9th, Wednesday. We'll be meeting. We have a very, very interesting and somewhat controversial speaker. So we'll be there. Thank you, everybody. Have a good day.
Thanks, everyone.
Thank you, Simon.
Bye-bye.